We would like to welcome Dr. Rupak Roy, who is a consultant at BBI Foundation, Kolkata, and he will be speaking on central serous chorioretinopathy today. Dr. Rupak Roy, welcome, sir. Please.
Thank you, Dr. Sinha. I'll be speaking of central serous chorioretinopathy. So, coming to epidemiology, CSCR ranks among the most common vision-threatening retinopathies after AMD, diabetic retinopathy, and branch retinal vein occlusion. A higher prevalence among men was observed in several studies, with 72 to 88% of cases occurred in male subjects. Recent epidemiological data report a higher mean age than generally assumed, ranging between 39 to 51 years. And in the Asian population, CSCR is frequent and severe, with bilateral and multifocal forms being reported more frequently than other ethnic groups. So there are certain predispositions like genetic, pachychoroid, which is a CT more than 390 microns, glucocorticoid use, pregnancy, Cushing syndrome, gastroesophageal disorders. Now, glucocorticoids in many forms can act as an precipitator of CSR. It can be oral, nasal, skin cream, inhaler, and epidural. There can be drug-induced CSR also, like sildenafil, tadalafil, oral MEK inhibitors like binimetinib for use for metastatic cancer, and adrenergic receptor antagonists like pseudoephedrine and oxymetazoline. So it has various clinical forms like acute, chronic, recurrent, and resolved. What are the signs and symptoms? It can have blurred vision, a relative central scotoma, a metamorphopsia, moderate dyschromotopsia, hypermetropization, micropsia, and reduced contrast sensitivity. Signs could be serous fluid, pigment epithelial detachment, pigment epitheliopathy, RP tracts, cystoid degenerations, and RP atrophy. Variants are unifocal, multifocal, and villous. So this is a classic case of a CSR. This is the case of a smokestack leakage. You can see there is multiple RP alterations here. So this is a case of a sick RP syndrome. OCT can assume various forms. This is a classic CSR with subretinal fluid that can be seen. Also, sometimes shredded photoreceptors as subretinal precipitates. PED is a common accompaniment of CSR, seen in almost 90% of patients. Very tall PEDs like this retina, it is a very chronic case of CSR. Cystoid degeneration, if there is a large cyst in a later stage of CSR. It's very useful to pick up the area of the leakage. Here you can see the area of the leakage exactly corresponding to the area of the leakage on FA. Indocyanine angiography shows mid peripheral hyperpermeability. What is the role of autofluorescence? In the case of CSR, you can see there are yellowish RP alterations. But to do autofluorescence, you can see the entire thing is black. That means there is no production of lipofuscin. That means the RP is dead. That means there is no activity here. This patient will not benefit visually whatever treatment we do for the patient. CSR can present such yellowish deposits which can mimic choroiditis, but on clear full FFA we can count this is actually a fibrin. This is the CSR with fibrin. Also a 25-year-old female, you can see a here, and on FFA you can see there are multiple pinpoint leakages and a disc leakage. So this is a case of a VKH. Also CSR can be seen along with VKH. The CSR leakage, and these multiple hypospots are corresponding to the VKH lesion. Interesting case where you see a subretinal fluid here, and there is some subretinal tissue here. On OCT angiography, you can see a nice membrane here. So this is the case of pachychoroid. What are the differentials? IPCV, pachychoroid vasculopathy, type 1 CNVM, VKH, neuropathy. So acute CSR observation is the treatment. Avoid stress and steroids. Review the patient after 2 months. Indications of early treatment are professional needs, CSR more than 3 months duration, recurrent CSR with visual deficit. Treatment extrafoveal leak, we can do thermal laser or PDT. Subfoveal leak, PDT is only indicated. In chronic CSR, PDT has to be done ICG guided. Chronic CSR, where SRF is persisting more than 4 months with no definite leaks, we can, and non-responding to PDT or laser, we can consider oral Eplerenone 25 to 50 milligram per day, once daily dosage, mineralocorticoid antagonist, minimum 3 months treatment. Side effects could be flu-like symptoms, hyperkalemia and dizziness. Thank you very much.